Welcome to the next lecture of our respiratory lecture series. And in order to encourage you to ask questions, there is a reminder for a giveaway. You can win Code Digital Littman Stethoscope, which is worth of around $379. How you can do it? Listen to our lectures, comment whatever you want to ask, any question or a recommendation for the next lecture. Follow us on Instagram, and if you like, then like and subscribe to the channel. Let's go. Today's topic. So today's topic is pulmonary embolism. These guidelines focus on the diagnosis and management of acute pulmonary embolism in adult patients. And in this lecture, I am focusing on recommendations of ERS and ESA Society 2019 guidelines of PE. In the next lecture, we can discuss in more detail about diagnosis and management, but in this lecture, I'm going to just focus on the recommendations. So let's begin. What the guidelines say about diagnosis? What are the recommendations for diagnosis? So guidelines divided into the patients who are hemodynamically unstable and hemodynamically stable. In suspected high-risk pulmonary embolism, as indicated by presence of hemodynamic instability, bedside echocardiography or emergency CTPA is recommended for diagnosis depending on availability and clinical circumstances. So if they are a high-risk patient, you can either go for bedside echo or emergency CTPA to diagnose pulmonary embolism, but it is recommended that IV anticoagulation with unfractionated heparin, including weight-adjusted bolus injection, may be initiated without delay in patient with suspected high-risk pulmonary embolism. So you should start treatment. Don't wait for the diagnosis. You can start treatment if without delay with suspected high-risk pulmonary embolism. They use the word hemodynamic instability. So hemodynamic instability is defined as either one of the following clinical manifestations at presentation. Either patient is in cardiac arrest and need for cardiopulmonary resuscitation, obstructive shock defined by systolic blood pressure of less than 90 or requirement of vasopressor to keep the blood pressure above 90, or end organ perfusion can be seen by altered mental sensorium, cold clammy skin, oliguria and urea, or increased serum lactate. Or persistent hypotension, systolic blood pressure of below 90 or systolic blood pressure drop of more than 40% lasting for more than 15 minutes and not caused by new onset erythema, hypovolemia or sepsis. So less than 90 or drop of more than 40 for more than 15 minutes is hemodynamic instability. Now for hemodynamic stable patient or without hemodynamic instability, the use of validated criteria for diagnosing PE is recommended. And initiation of anticoagulation is recommended without delay in patient with high or intermediate clinical probability of PE while a diagnostic workup is in progress. You can plan up the workup, start treatment, and you can use a validated criteria so that PE can be diagnosed. Clinical evaluation. It is recommended that diagnostic strategy be based on clinical probability, assessed either by clinical judgment or validated prediction rule. So we will discuss what is the clinical probability and how it is divided into high clinical probability, intermediate high, intermediate low, and low clinical probability later on, and what are the validated prediction rules or scores which help in diagnose PE. In diagnostic evaluation, the next recommendation is about D-dimer. So plasma D-dimer measurements, preferably using a high sensitivity assay, is recommended in outpatient or emergency department. Patient with a low or intermediate clinical probability, those that are P unlikely to reduce the need for unnecessarily imaging and irradiation. So guidelines are very clear. If you're suspecting that the clinical probability of pulmonary embolism is low or intermediate, in order to rule out PE, you can use D-dimer. But it should not be used in high clinical probability. As an alternative to fixed D-dimer cutoff, a negative D-dimer test using an age-adjusted cutoff, age into 10, in patients above 50 years should be considered for excluding PE with low or intermediate clinical probability or those with a P unlikely. So P unlikely or low or intermediate risk, you can do D-dimer, fixed D-dimer cutoff or age-adjusted D-dimer can be used and you can rule out PE. D-dimer measurement is not recommended in patients with high clinical probability as a normal result does not safely exclude PE even when using a high sensitive assay. So D-dimer is not recommended in patient with a high clinical probability. So if you're suspecting that this patient fall into a category of high clinical probability of PE, then even the D-dimer is normal. You cannot rule out. You cannot exclude PE. You should go for further testing in order to rule out PE. This is very important, especially for BCQ's point of view. CTPA. It is recommended to reject the diagnosis of pulmonary embolism without further testing if CTPA is normal. In a patient with low or intermediate clinical probability or in whom PE is unlikely. So if you categorize the patient into low or intermediate clinical probability and CTPA is negative, you can safely say that this is not PE. You can safely reject the diagnosis of pulmonary embolism. It is recommended to accept the diagnosis of pulmonary embolism without further testing if CTPA shows a segmental or more proximal filling defect in a patient with intermediate or higher clinical probability. And if CTPA is showing a filling defect, segmental or more proximal filling defect, you can safely say that this is pulmonary embolism. It should be considered to reject the diagnosis of pulmonary embolism without further testing if CTPA is normal in a patient with high clinical probability or whom PE is likely. So if the CTPA is negative, you can safely say that this is not pulmonary embolism. Either it fall into low, intermediate or high clinical probability criteria. You can safely categorize the patient as it is unlikely PE and rule out the other diagnosis. Further imaging tests to confirm PE may be considered in case of isolated subsegmental filling defects. But if there are isolated subsegmental defects coming up, then you can do further imaging to confirm the diagnosis. CT venography is not recommended as an adjuvant to CTPA. So there is no need to do CT venography. VQ scintigraphy. It is recommended to reject the diagnosis of pulmonary embolism without further testing if perfusion lung scan is normal. So perfusion VQ scan normal, there is no P. It should be considered to accept the diagnosis of pulmonary embolism without further testing if VQ yields a high probability for PE. If perfusion scan shows pulmonary embolism, then you can accept the diagnosis of pulmonary embolism. A non-diagnostic VQ scan should be considered as an exclusion of pulmonary embolism when combined with a negative proximal compression ultrasonography in patients with low clinical probability or whom PE unlikely. So, non-diagnostic VQ scan should be considered as an exclusion of PE if there is a clinical low probability and there is negative proximal compression ultrasonography and VQ scan is non-diagnostic, you can exclude pulmonary embolism. VQ SPECT may be considered for VQ PE diagnosis, so SPECT scan can be considered for the diagnosis of pulmonary embolism. Lower limb compression ultrasound. It is recommended to accept the diagnosis of venous thromboembolism and PE if compression sonography show a proximal DVT in a patient with a clinical suspicion of pulmonary embolism. If leg Doppler ultrasound, compression ultrasound is showing that there is a proximal DVT, you can accept the diagnosis of venous thromboembolism and suspect PE. If compression ultrasound show only a distal DVT, so it is for proximal DVT. If it is a distal DVT, then further testing should be considered to confirm pulmonary embolism. If a positive proximal compression ultrasound is used to confirm pulmonary embolism, assessment of pulmonary embolism severity should be considered to permit risk-adjusted management. If a proximal compression ultrasonograph is used to confirm PE, then you have to classify the pulmonary embolism severity, which we will learn later on, to permit that this is a risk adjusted and we should start a management. MRA, magnetic resonance angiography, is not recommended for ruling out PE according to the guidelines. Now, prognostic assessment. So, up till now we were discussing diagnosis. Now we will focus on prognostic assessment. Initial risk stratification of suspected or confirmed pulmonary embolism based on the presence of hemodynamic instability is recommended to identify patients at high risk of early mortality. So if the patient is hemodynamically unstable, you have to classify them into risk stratification so that we can find out if it's in high risk of early mortality or not. In patients it's without hemodynamic instability, further stratification of patients with acute PE into intermediate and low risk categories is recommended. In a patients without hemodynamic instability, the use of clinical prediction rules integrating pulmonary embolism, severity and comorbidity, preferably PASI or simplified PASI, should be considered for risk assessment of acute phase of PE. So if the patient is stable, not hemodynamically compromised, according to the definition we studied before, we can classify the patients into severity by using a PASI score or simplified PASI score. What is PESI score? It is original and simplified pulmonary embolism severity index. So PESI, there is an original version and there is a simplified version. Simplified version include age, cancer history, chronic heart failure, chronic pulmonary disease history, pulse rate of more than 110, systolic blood pressure of less than 100, or sets of less than 90. It's only include 1 point if age is more than 80 years, and it is classified into 0 points and more than 1 or more than 1.0 point is equal to 30-day mortality risk of 1%, and 1 or more than 1 point is equal to 30-day mortality risk of 10.9%. So original score include various factors and their point sheet is also different. The maximum points are for altered mental status, which is 60 points, and how much age in years included, and the score increase. Male include 10 points, cancer include 30 points, chronic heart failure 10 points, chronic pulmonary disease 10 points, pulse rate of more than 110 20 points, systolic blood pressure of less than 100 30 points, respiratory rate of more than 30 breaths per minute 20 points, temperature less than 36 20 points. As we discuss, altered mental status 60 points, sets of less than 90 20 points, and it classified into 5 classes. Class 1 less than or equal to 65 points, very low 30-day mortality risk of 0 to 1.6%. Class 2 is 66 to 85 points, low mortality risk of 1.7 to 3.5%. Class 3 is 86 to 105 points, moderate mortality risk 3.2 to 7.1%. Class 4 is 106 to 125 points, high mortality risk of 4 to 11.4%. Class 5 more than 125 points, very high mortality of 10 to 24.5%. So whenever patient is coming with hemodynamic stability, who can calculate the PESI score or simplified PESI score and can classify the patient into the class 1, 2, 3, 4, 5 or point 0, or if you are calculating it with a simplified PESI score into 0 points or 1 or more than 1 point, so that we know if there is a high risk of early mortality there or not. Assessment of right ventricle by imaging methods or laboratory markers should be considered even in the presence of low PESI or negative simplified PESI score. So this is a new point in the guidelines which is added, and it says that even if the simplified PESI score is negative or the PESI score is low, you should check for the right ventricle strain by either imaging methods using echocardiogram or laboratory methods, which we'll discuss later on, includes troponin or BNP. In patients without hemodynamic instability, the use of validated score combining clinical imaging, laboratory PE-related diagnostic factors may be considered to further stratify the severity of acute PE. And how to do that? So, whenever you are diagnosing a patient of pulmonary embolism, you have to classify the severity of pulmonary embolism and identify the risk of early death. How you do that? Early mortality risk are high, intermediate low, or low. And what are the indicators of risk they are for? Hemodynamic instability, clinical parameters of PE severity or comorbidity or PESI class 3 or 5 or simplified PESI score of more than 1 or more than 1, right ventricle dysfunction on echo or CTPA, elevated troponin levels. So as you can see, if the patient is hemodynamic unstable or the PESI score is high or RV dysfunction either on imaging or either trop levels are high, this is classified as a high severity and there is a high risk of mortality in hospital for 30 days. If either of them are present with hemodynamic instability, it is high risk. If three of them are present but no hemodynamic instability, then it is intermediate high risk. If PASI score is high but one of them positive in RV dysfunction, either imaging or either troponin, then it is intermediate low. And if they are negative, means patient is hemodynamically stable, PASI scores or simplified PASI score is low. There is no evidence of RV, right ventricle dysfunction, or either imaging by echocardiogram, CTPA, or troponin levels. Then it means it is a low probability of or low severity of early mortality risk. Now we are coming to the treatment phase. Recommendations for acute phase treatment of high-risk pulmonary embolism. So for high-risk pulmonary embolism treatment, it is recommended that anticoagulation with unfractionated heparin, including weight-adjusted bolus injection, be initiated without delay in patient is suspected high-risk PE. If it is high risk, you are considering it could be PE, you should start treatment. Systemic thrombolytic therapy is recommended for high-risk PE. If patient is hemodynamically compromised, you can start a systemic thrombolytic therapy. We will later on discuss include TPA and all. If thrombolytic is contraindicated, you can go for embolectomy. Surgical pulmonary embolectomy is recommended for patient with high risk PE for whom thrombolysis is contraindicated or has failed. Percutaneous catheter-directed treatment should be considered for patients with high-risk PE in whom thrombolysis is contraindicated or has failed. So if thrombolysis is contraindicated or failed, we have the other options are pulmonary embolectomy or catheter-directed treatment. Non-epi or dobutamine should be considered in patients with high-risk pulmonary embolism. They are dropping blood pressures. ECMO may be considered in combination with surgical embolectomy or catheter-directed treatment in patients with PE and refractory circulatory collapse or cardiac arrest. Now the recommendations for intermediate and low-risk pulmonary embolism patients. Initiation of anticoagulation. Initiation of anticoagulation is recommended without delay in patients with high or intermediate clinical probability of PE while a diagnostic workup is in progress. So simultaneously treatment and diagnosis can be planned. If anticoagulation is initiated parenterally, low molecular weight heparin or fondaparinux is recommended. Low molecular weight heparin in most of the patients. When oral anticoagulation is started in patient with PE who is eligible for non-vitamin K oral anticoagulants, which is apixaban, dabigatran, edoxaban, or rivaroxaban, a NOAC is recommended in preference to vitamin K antagonist warfarin. So nowadays, oral anticoagulants are preferable as warfarin because it is easy to go and you don't need INR monitoring in these patients. When a patients are treated with vitamin K antagonist, which is warfarin, overlapping with parenteral anticoagulation is recommended until INR is 2.5 reach. So you start with unfractionated heparin and then overlap it with vitamin K antagonist once INR of 2.5 achieved. NOACs are not recommended in patients with severe renal impairment, pregnancy and lactation, and EPLA. So there are certain contraindications for oral non-vitamin K oral anticoagulants, renal impairment, pregnancy, lactation, and EPLA. So next is reperfusion treatment. Rescue thrombolytic therapy is recommended for patients with hemodynamic deterioration on anticoagulation treatment. As an alternative to rescue thrombolytic therapy, Surgical embolectomy or percutaneous catheter-directed treatment should be considered for patients with hemodynamic deterioration on anticoagulation treatment. So if any patient already on treatment and uh, is still thrombosis is there, you can start with a rescue thrombolytic therapy in the form of surgical embolectomy or percutaneous catheter-directed treatment. Routine use of primary systemic thrombolysis is not recommended in patients with intermediate or high risk pulmonary embolism. So you don't need to thrombolyze patients if they have intermediate or low risk pulmonary embolism. Always involve multidisciplinary team in making decisions. Recommendations for inferior vena cava filters. IVC filters should be considered in patients with acute PE and absolute contraindications to anticoagulation. If there is an absolute contraindication to anticoagulation you cannot give, then IVC filter can be used, or IVC filters should be considered in case of PE reoccurrence despite therapeutic anticoagulation. So first of all, if anticoagulation is contraindicated. Second, if there is a reoccurrence, but routine use is not recommended. Recommendations for early discharge and home treatment. Careful selected patients with low risk PE should be considered for early discharge and continuation of treatment at home. If proper outpatient care and anticoagulant treatment can be provided, you can discharge these patients. Now, duration. Recommendations for the regime and duration of anticoagulation after PE in patient without cancer. So therapeutic anticoagulation of more than or equal to 3 months is recommended in all patients with PE. So at least for 3 months you should be giving. For patients with first PE or VTE secondary to a major transient reversible risk factors, discontinuation of therapeutic oral anticoagulation is recommended after 3 months. If you know the risk factor behind behind PE, and that factor has been removed now, you can discontinue oral anticoagulation after 3 months. Oral anticoagulant treatment of indefinite duration is recommended for patients presenting with recurrent VTE, that is with at least one previous episode not related to major or transient reversible risk factor. If it is not related to a major or transient reversible factors, so for indefinite period of time we have to continue anticoagulation. Oral anticoagulation treatment with vitamin K antagonist warfarin for an indefinite period is recommended for patients with APLA, antiphospholipid antibody syndrome. Extended oral anticoagulation of indefinite duration should be considered for patients with first episode of PE with no identifiable risk factor. So as you can see, indefinite period we are using if you don't know the risk factors, if it's recurrent VE, if it's EPLA, if you don't know the risk factor. An extended oral anticoagulation of indefinite duration should be considered for patients with first episode of PE associated with persistent risk factor other than EPLA. Extended oral anticoagulation of indefinite duration should be considered for patients with first episode of PE associated with minor transient or reversible risk factor. Even if it's minor, you have to continue it for indefinite period of time. If extended oral anticoagulation is decided after PE in a patient without cancer, reduced dose of NOACs or non-vitamin K oral anticoagulants like Pexipan of 2.5 milligrams BID or Rivaroxaban of 10 milligrams OD should be considered after 6 months of therapeutic anticoagulation. So after 6 months, you are giving full doses, and after that you can reduce the dose if the patient has no cancer. In a patient who refuses to take or unable to take or tolerate any form of oral anticoagulants, then in some cases you can use alternatives, but uh, very low data on research base. In a patients who receive extended anticoagulation, it is recommended that their drug tolerance and adherence, hepatic and renal function, and bleeding risk be assessed at regular intervals. So you should be reviewing LFTs renal functions, and bleeding risk. Recommendations for the regime and duration of anticoagulants after pulmonary embolism with active cancer patients. For patients with PE and cancer, weight-adjusted subcutaneous low molecular weight heparin should be considered for first 6 months over vitamin K antagonist or warfarin. So you have to start with subcutaneous low molecular weight heparin at least for the first 6 months. Edoxaban should be considered as an alternative to weight-adjusted subcutaneous low molecular weight heparin in patients without GI cancers, or rivaroxaban should be considered. So if there is no GI cancer, you can use either edoxaban or rivaroxaban. For patients with PE and cancer, extended anticoagulation beyond first 6 months should be considered for indefinite period or until the cancer is being cured. So you might need to give it for a longer period of time unless and until the cancer has been cured. You have to give anticoagulation. In a patient with cancers, management of incidental PE in the same manner as a symptomatic PE should be considered if it involves segmental or more proximal branches, multiple subsegmental vessels, or a single subsegmental vessels in association with proven DVT. So you should be treating the patient if it's identified accidentally, incidentally, or the patient is asymptomatic, you have to treat it same as you are treating patient who are symptomatic. So this is done. We'll discuss other recommendations of the same guidelines in another lecture. Thank you.